Thank you, Dr. Boice, for sharing these lessons and important considerations with us. You mentioned that when we get above a certain dose of radiation, we see a clear dose-response relationship and have fairly reliable cancer risk estimates. And most of your discussion today about quality of epidemiological studies and much of the debate about carcinogenicity of radiation focuses on low and very low doses of radiation, particularly those doses delivered gradually over time. So my follow-up questions for you are all regarding these low dose and low dose rate exposures. You said that we live in a sea of low-level environmental radiation, which is a great analogy. And the question today is not whether radiation causes cancer, but how much cancer is caused by low-level radiation. My first question is, should we be worried about this sea of radiation that we live in?
The low-level radiation that surrounds us is not a concern, except for radon in some homes. The radiation doses that we receive from naturally occurring radiation sources, such as environmental radiation, cosmic rays, radioactive elements in the food that we eat, and most indoor radon exposures are generally so tiny as not to be a health concern. Living in a sea of radiation is to remind us that we all experience low doses of radiation throughout our lives associated with naturally occurring ubiquitous background radiation without evidence for health effects. The one exception, however, is the high radon levels that can be found in some homes even today. Recently in Pennsylvania, a few homes were found to have levels equivalent and higher than what was measured in underground uranium mines of years past. Such levels required immediate evacuation of the family. Thankfully, such extremely high levels are very rare in the United States, but they do occur. Thus, EPA has recommended strongly that homes be monitored for radon, and if high levels are found, remediation action should be taken.
My next question, Dr. Boice, is about cancer risk coefficients derived for very low doses. All scientific committees and international scientific institutions who review the literature and provide radiation protection guidance say that it is not appropriate to use a risk coefficient derived for very low doses and apply that to a large population to calculate or predict future health effects. For example, if the calculated risk coefficient for a low-dose exposure is, say, 0.1% for developing cancer, it is not appropriate to multiply 0.1% by a population of 1 million persons exposed and predict 1,000 cancers in that population because of that low-dose exposure. This seems to many a logical approach, and it's also a practice we see quite often in news reporting. Please explain the reason why this practice is inappropriate and misleading.
This is an important question and an issue that is greatly misunderstood. For radiation protection and as a way of managing low doses received in occupational or environmental circumstances, we select a radiation dose-response model that can be used to help manage low-dose exposures and provide adequate measures of protection. Today, we use the linear, non-threshold model. It's been used for over 40 years in radiation protection. The error that you're referring to is using collective dose inappropriately. Collective dose is a radiation protection term where all the estimated individual doses in a population are summed together, and different strategies might be considered to lower this collective dose as a means for dose management. Simply stated, applying the ALARA principle, or as low as reasonably achievable. The NCRP, ICRP, United Nations, and other scientific organizations clearly and frequently state that it is inappropriate and wrong to multiply a very tiny risk estimate that comes from a protection model and not a health effects model, where the possibility of any health effects is unknown and could be zero, and then multiply this tiny estimate times a large population and come up with a theoretical and inappropriate estimate of the number of cancer deaths associated with these very low-dose exposures. Said a bit more simply, it is inappropriate and misleading to use a model that is for radiation protection and dose management with its many uncertainties and assumptions to then assume that the same model is applicable to estimating an individual's risk of health effects from low-level exposures in a population.
Thank you. You mentioned, Dr. Boice, that in addition to the mainstream scientific consensus, which we've arrived at after more than 100 years of research, there are two groups on opposing ends of the spectrum in the field of radiation protection. One of these groups are those who believe radiation at very low doses are in reality good for us, and perhaps we should encourage such chronic low-dose exposures for good health. Proponents of this view claim that there are many scientific studies which support their view. Please tell us why you disagree.
Well, I disagree because there are no epidemiologic studies of high quality, the qualities which we talked about today, that support their view. NCRP just reviewed 29 recent human research studies of low-dose radiation exposure and concluded that, while imperfect, the linear non-threshold model continued to be appropriate to use for radiation protection. Without going into too much detail, the claims for protective effects at low doses are not substantiated. The National Academy of Sciences, the United Nations Scientific Committee on the Effects of Atomic Radiation, the NCRP, and the ICRP are among the many reputable scientific organizations dealing with radiation that continually evaluate studies about effects of low-dose radiation and do not support the view that low doses of radiation are good for you.
Thank you, Dr. Boice. My last question is, given the body of scientific literature we have on health effects of radiation, would it be fair to say that as a consumer of information, we should seldom, if ever, rely on results of a single study to draw conclusions? And instead, we should look at the consensus view of the scientific community, which is based on results from multitude of studies accumulated over decades of research.
Exactly right. In epidemiology in general, when we're making decisions regarding the causal nature of an exposure, it's always the case that consistency in other studies conducted in other areas and by other investigators is one of the strongest factors when such judgment is made. For example, it took many years for the Surgeon General to be convinced that smoking is a health hazard and a prime cause of lung cancer. There needed to be a wide variety of evidence, including the consistency of human studies that were just coming out. For radiation protection and radiation understanding, the atomic bomb survivor study is used extensively despite many limitations. But even here, it's the relative consistency of the A-bomb data with other studies, primarily in the medical arena, that supports its use. For example, the consistency of breast cancer, thyroid cancer, and leukemia results from the A-bomb study with 3 to 5 other high-quality epidemiologic studies provide support for the causal associations reported in the atomic bomb survivor study, although not necessarily the level of risk due to radiation. As discussed throughout these interviews, the manager, scientist, and health professional must take caution when dazzling results are presented that have never been seen in other studies. Although there are associations reported in several of the studies discussed, they could be ruled out as non-informative just because they stood alone and were not consistent with the evidence accrued over the past 100 years. So it's very important to look for consensus of findings across epidemiologic studies and to read carefully the consensus reviews by the many scientific organizations that are constantly reviewing the radiation literature in order to provide guidance to authorities who have the responsibility to protect workers and the public.
Thank you, John. Thank you.
You're very welcome.
Excellent.